In this video, we are going to discuss about the recreational drugs and their anesthetic implications. First one, we are going to discuss about cannabis. It is marijuana. The street names are blunt, bud, dope, ganja, weed. The common forms available are greenish-gray mixture of dried leaves, stems, and seeds. On acute intoxication, it produces CNS effects as enhanced sensory perception, euphoria, followed by drowsiness, slow reaction time, problems with memory, hallucination. On cardiovascular system, it has effects as abnormal heart rate, blood pressure, increased risk of myocardial infarction, arrhythmias. On chronic intoxication, it produces mental health issues. With respiratory system, it produces chronic cough, frequent respiratory infections. On cardiovascular system, it produces orthostatic hypotension and predisposition to ischemic heart disease. It also produces carboxyhemoglobinemia. The withdrawal symptoms are irritability, trouble sleeping, decreased appetite, and anxiety. The medications for withdrawal, none of them is approved, but proposed medications are benzodiazepines and nabilone. The anesthetic implications of cannabis. On the respiratory system, it produces damage to respiratory mucosa, upper airway irritability, edema, obstruction, bronchitis, emphysema, bronchospasm. These symptoms could be relieved by dexamethasone. They also produce risk of SVT, STT changes, hypertension, myocardial infarction, postural hypotension. There is increased requirement of propofol for induction. Cannabis prolongs the sedative action of GA. The drug interactions. With the metabolism through CYP3A4, it interacts with fentanyl, oxycodone, and codeine. With the interaction with the CYP2C9 enzyme in the liver, it produces interaction with warfarin, NSAIDs, clopidogrel, celecoxib. Second in the list is cocaine. The street names are blow, bum, candy, coke, crack. The common forms it is available as white powder or whitish rock crystal. It is snorted or rubbed into the gums, dissolved in water and injected, or mixed with heroin called as speedball. On acute intoxication in cardiovascular system, it produces vasoconstriction, increased heart rate, increased blood pressure, myocardial infarction, and arrhythmias. On central nervous system, it produces headache, euphoria, alertness, insomnia, restlessness, anxiety, erratic violent behavior, paranoia, psychosis, seizures, coma. It produces mydriasis and it increases body temperature. On chronic intoxication, as it is inhaled through the nose, it produces loss of smell, epistaxis, nasal damage, trouble swallowing from snorting. It leads to infection, respiratory infections, aspiration, pneumonia, lung abscess, pulmonary edema, barotrauma, pulmonary infarction. Due to poor nutrition, it produces weight loss. It also produces hypertension on chronic use. Withdrawal symptoms are depression, insomnia, increased appetite, unpleasant dreams, slow thinking, and restlessness. The medications for withdrawal, none of them is approved, but proposed medications are propranolol and dexmedetomidine. Now we'll see anesthetic implications of cocaine. The regional anesthesia is difficult because there is lack of cooperation of the patient during acute intoxication. The beta blockers are contraindicated for increased blood pressure and increased heart rate because there is increased or unopposed alpha stimulation. So it will deteriorate the blood pressure and heart rate. The calcium channel blockers produce tachycardia. The drug of choice for hypertension and CNS excitation is dexmedetomidine. For treatment of hypertension, the drug of choice is nitrates and nitroprusside. If hypotension is seen in cocaine overdose, use phenylephrine as ephedrine, as we would encounter the ephedrine resistance. During the direct laryngoscopy, there is hypertensive response. Etomidate, if used for induction, causes myoclonus, seizures, hyperreflexia. We have to avoid ketamine. Propofol is safe for induction. Anesthetic implications continued. It prolongs the succinylcholine duration because it binds to the pseudocholinesterase enzyme and it inhibits the metabolism of succinylcholine. It produces thrombocytopenia. So we have to look at the platelet count during regional anesthesia. There should be caution with NG tube placement because there is risk of septal perforation and soft palate necrosis. Next in the list comes heroin. It's a form of opioid. The street names are brown sugar, dope, junk, smack. With over-the-counter cold medication and antihistaminic, it is called as cheese. The common forms available are white or brownish powder. The black sticky substance is called as black tar heroin. On acute intoxication, the central nervous system effects are euphoria, alternate wakefulness and drowsiness, clouded thinking. On respiratory system, it produces slow breathing. On cardiovascular system, it produces slow heart rate. It also produces nausea, vomiting, warm flushing of skin, dry mouth, heavy feeling in hands and feet. The antidote for acute intoxication is naltrexone. On chronic intoxication, it has the patient have collapsed vents. There are chances of infective endocarditis, septic emboli, skin abscess, pneumonia, and lung abscess. Withdrawal symptoms are restlessness, muscle cramp, bone pain, insomnia, diarrhea, vomiting, cold flashes with goosebumps. It is also called as cold turkey and leg movements. Medications for withdrawal, none of them is approved, but proposed medications are methadone and buprenorphine. Anesthetic implications of heroin and prescribed opioids are there is chances of difficult peripheral IV access, delayed gastric emptying due to opioid effect, decreased intravascular volume, so there is risk of hypotension with general anesthesia or regional anesthesia. Difficult perioperative pain management due to tolerance and hyperalgesic state due to opioid overdose. So for the treatment of pain in the perioperative period, we need higher doses of opioids. Ketamine to treat the opioid-induced hyperalgesia. We can try NSAIDs if not contraindicated. Gabapentinoids like gabapentin and pregabalin and the use of local anesthetics where possible. We have to continue methadone if patient is on opioid withdrawal program. If patient is on buprenorphine, then stop it 24 to 36 hours before the surgery and replace it with full agonist like fentanyl. It can be restarted when full agonist analgesia is not needed. If the patient is naltrexone, discontinue its use before the surgery. Next in the list are hallucinogens. Ketamine, the street names are cat Valium, Special K. It is also known as day trip drug. It is available in the common form such as liquid or white powder. On acute intoxication, it produces dream-like state, hallucination, sedation, confusion, increased blood pressure, and slow breathing. On chronic intoxication, it produces ulcer and pain in the bladder, depression, poor memory. The withdrawal symptoms are headache, anxiety, palpitation, sweating. No medications are proposed for withdrawal. The anesthetic implications of ketamine. We have to monitor body temperature. Benzodiazepines, antipsychotics drugs can be used to treat dysphoric hallucination in acute phase. There is exaggerated response to sympathomimetic drugs, for example, ephedrine. The LSD and PCP are the hallucinogens which prolong the succinylcholine by inhibiting the action of plasma cholinesterase. Next in the list are ecstasy or MDMA. The street names are Adam or Speed. The common forms available are colorful tablets, powder, or liquid. On acute intoxication, it lowers the inhibition, produces confusion, muscle tension, teeth clenching, rhabdomyolysis, increased body temperature, hyponatremia, liver, kidney, and heart failure. It can lead to death. On chronic intoxication, it produces confusion, anxiety, aggression, loss of appetite. The withdrawal symptoms are fatigue and anxiety. None of the medication is approved for withdrawal. The anesthetic implications are it produces dehydration, so excessive drinking and high ADH leads to hyponatremia. There are chances of pulmonary edema, so anesthetic implications should include management of pulmonary edema, hypertension, rhabdomyolysis, hyperthermia, seizures, cerebrovascular accidents, and liver failure. The drugs such as benzodiazepines, non-depolarizing muscle relaxants, and propofol are safe for induction of anesthesia. Next in the list are methamphetamine. The street names are crank or chalk. The common forms available as white powder or pill. On acute intoxication, it produces increased wakefulness, increased physical activity, reduced appetite, increased respiratory rate, increased heart rate, increased blood pressure, increased temperature, and arrhythmias. On chronic intoxication, it produces anxiety, confusion, hallucination, itching, and dental issue. Withdrawal symptoms are depression, anxiety, tiredness.